Yes, ma'am, you can go live. Yeah, no.
Good evening, everyone, and a very warm welcome to you from the team Gennova. Myself, Dr. Shrutal Deshmukh, and I welcome you all to this stroke intervention story. The objective of this workshop is to bring forth the curated, interesting stroke cases and share the knowledge and insights with the larger group of audience. So, without further ado, let's start the session. But let me first start with the introduction of the panelists.
Uh, I'm sorry to interrupt. The screen isn't visible yet.
Sharing the screen right now. I'll be sharing it. Yes, I'm sharing it right now. Yes. So is my screen visible now?
Yes.
Yeah, thank you so much. So we have for today Dr. Anand Alurkar as a course director. Sir is an interventional neurologist and stroke specialist at KM Hospital and Jahangir Hospital, Pune. Sir has got 20 plus years of experience in stroke and neurovascular intervention and the first formally trained specialist in the interventional neurology in India and of course pioneer in Pune. Sir hold expertise in the endovascular treatment of ischemic and hemorrhagic stroke, including thrombectomy, stenting, and aneurysmal coiling. And sir has also extensive experience in the stroke care system and hold various expertise in diagnostic cerebral angiographies and neurointerventions as well. Apart from that, he has got many credentials to his CV edits. We are very much delighted to have you, sir, as course director for today. A very warm welcome to you, sir.
Thank you.
As a moderator today, we have Dr. Shripal Shah, who is the head neurology and neurointervention at Sahyadri Super Speciality Hospital, Nashik. Sir holds 15 plus years of experience in comprehensive stroke care and neurovascular intervention and is pioneer in establishing advanced stroke and neurointervention services across North Maharashtra. Sir holds expertise in mechanical thrombectomy, cerebral angiography, stenting, and aneurysmal coiling. And apart from that, he has got 5,000 plus cerebral angiographies and thrombectomies and also hold expertise in carotid stenting. A very warm welcome to you, sir. Sir would be joining with us shortly. He's not there. So, but a warm welcome from the team Gennova. We are also very much pleased and delighted to welcome on board Dr. Rakesh Singh as a moderator for today, who is a consultant neurologist and neurointerventional specialist at Bombay at SL Raja Hospital and Bombay Hospital, Mumbai, and hold an expertise of 17 years in stroke management, neurovascular intervention, and minimally invasive brain and spinal procedure. Sir has got also expertise in hyperacute stroke management, mechanical thrombectomy, aneurysmal coiling, and carotid stenting. He is also has done advanced fellowship in neurointervention from Germany and has performed 50 plus flow diverter stent procedure and has got expertise in mechanical thrombectomy and complex cerebrovascular intervention. A very warm welcome to you, sir. We are very much delighted to have you on board today. Next, let me introduce our speaker for today, Dr. Vineet Banga, who is Director and Head Neurology and Neurovascular Intervention at Fortis Hospital, Faridabad, and Fortis Heart Institute, New Delhi. Sir is a senior neurologist and neurointervention specialist with expertise in acute stroke management and neurovascular intervention and endovascular treatment of cerebrovascular disorder. Sir holds expertise in stroke intervention, mechanical thrombectomy, and aneurysm management. And he is also active in clinical research, academic teaching, and training in neurointervention. Not to mention, sir is a gold medalist in MD and also a lifetime member of Indian Stroke Association and several national and international neurology societies. And would also like to have a special mention that he is a recipient of World Stroke Organization Young Stroke Professional Scholarship. A very warm welcome to you, sir.
Thank you.
Let me take the honors to welcome our next speaker for today, Dr. Narayan Deshmukh, who is a consultant and interventional neurologist at Mahavir Hospital, Medicover Hospital, and Hegdewar Hospital at Chhatrapati Sambhajinagar. Sir hold an expertise in acute stroke management, neurovascular intervention, and endovascular treatment of cerebrovascular disorder. And sir is also expertise in stroke intervention, and he is consultant at the leading multi-speciality hospital at Chhatrapati Sambhajinagar as well. And he is actively involved in comprehensive stroke care and neuro intervention. A very warm welcome to you, sir.
Thank you.
So without further delay, let me hand over the session to our course director today to drive the session forward. Thank you.
Yeah, thank you, Dr. Shrutal. So I think this is our third session, right?
Yes.
So there is no need of any special introduction. We all know why we are having this session. And it's been a pleasure that Gennova has been involved in this academic activity. So we'll start with the cases right away. Who wants to go first? Dr. Narayan, Dr. Vinit?
Sir, can I start?
Sure, you can start, Narayan.
So the presentation is visible, right?
Yes, sir, it's visible.
Yeah, I would thank the organizers for this opportunity, and sir also. Hopefully, in next 15 minutes, I'll be able to take you through this interesting case I had. So this 54-year-old
So you need to
gentleman
go full
was,
screen. Sir, you need to go full screen.
is it seen right now? Slide share right now,
Yeah.
actually. Can you see?
Yes, sir. We can see you. Can continue.
Okay. So this was a 54-year-old man who presented with acute onset slurring of speech, which was progressing over 1 hour. He visited a neurologist who suggested an MR angio, and he was contemplating for intravenous thrombolysis when I got call for this patient. So while he undergoes this MR angio, let me take you through a bit of flashback for the same patient. He had presented a year ago with left-sided weakness. Power around 2 to 3, was unable to walk. There was mild dysarthria. Premorbid, he was diabetic, hypertensive, and dyslipidemic with a regular follow-up to the physician. He also had deep vein thrombosis in December 2023, took treatment for 6 months. And at present, at the time of this stroke, he was off medications for the same. So the MR angio done that time showed acute infarcts in the right MCS subcortical region and extensive chronic ischemic changes seen on FLAIR images. The top sequence showed a critical stenosis of right ICA origin, mild to moderate stenosis of left ICA origin, and fairly well intracranial circulation. Both the MCs were filling normally. So a DSA was advised, and it showed pretty classical critical stenosis of the right ICA origin. Other investigation, the only significant ones, he had raised hemoglobin and PCV, borderline deranged sugars, LDL was 166, and fairly preserved cardiac function with a EF of 53. He had an old right inferior wall MI with regional wall motion abnormality, but there was no LV clot. So decided to go ahead with carotid stenting as it was a critical stenosis of the extracranial carotid causing ipsilateral stroke. So we generally give ecosprin 150 and clopidogrel as dual antiplatelet therapy at least 4 to 5 days prior to stenting with high dose statin. He received for total 8 days duration prior to stenting. Meanwhile, patient also improved. He was ambulatory with support. And I proceeded with the carotid stenting. So this was a pre-critical stenosis. Anabolic protection device was deployed. Balloon angioplasty was done, and then stent was deployed uneventfully. The usual protocol for usual protocol for carotid stenting, 5,000 units of heparin, embolic protection device, pre-plasty, then deploying stent, doing at times post-plasty. In this case, after retrieving EPD, I found that there was a small plaque, atherosclerotic plaque in the EPD. So for routine case. But as I was just writing the procedure notes and explaining, 25 minutes later, I was informed that the patient had developed left-sided weakness and the dysarthria had worsened. Immediately BP was checked, it was normal. Now, what's the possibility for immediately post-procedure weakness, usually either it's a stent thrombosis or bleed. Since the sheath was there, patient was right beside the cath lab, so shifted from ICU to cath lab, and the stent was feeling pretty well. There was no intraluminal clot, there was no stent thrombosis. Even the intracranial run showed pretty normal feeling of both the MCA and ACS. So there was no large vessel occlusion, relatively well preserved intracranial flow. Uh, So post DSA, he had received his antiplatelet drugs a day before, night before. So I had given ecosprin and ticagrelor while maintaining a blood pressure target of 90 to 120 systolic. Shifted back again to ICU, and I was just contemplating what could have gone wrong. So at times, what happens is during post dilatation, there could be microembolism of the plaque getting ruptured. Actually, the plaque was caught up even in the embolic protection device, but I don't know what happened. The other possibility was a cerebral hyperperfusion, as there was a critical stenosis of this side and the contralateral stenosis on the moderate side. Was there a possibility of bleed? Definitely. 9 hours later, the nightmare continued. Now the power was absolutely zero. The speech was incomprehensible. The patient developed right gaze. BP was normal. Now what? I mean, was it a delayed stent thrombosis? Was there a bleed or possibly a large infarct? So did a CT immediately. There was no bleed, there was no hypodensity, but as you can see, there was this hemispheric edema which was seen. So was it developing a hyperperfusion? Again, the treatment is continuing, the supportive care, maintaining blood pressure, and everything was shifted back to ICU. But before doing that, I decided again to go ahead with a check angio. This was second DSA at night. Same findings like morning. The stent was patent. The MCA and ACA were feeling normally. There was no large vessel occlusion. Patient was shifted to ICU, and next day morning, I got a call that the patient has had first episode of focal onset seizure, which was generalized, and they were progressively increasing in frequency. Fortunately, he was regaining consciousness in between the seizure episodes, which happened throughout the course. Immediate investigations were all normal. So during the ICU course, he was given multiple anticonvulsants, levetiracetam, iptoin, valparin, lacosamide, even perampanel was added. So total 5, 6 anticonvulsants, given magnesium steroids, continued on dual antiplatelet and statin. All the supportive care was being taken care of. So this case was somewhat similar to what I had the opportunity to publish. This was my first paper with Rakesh Singh sir, Karapurkar sir, and Khadilkar sir, that new onset refractory status epilepticus is a known rare complication of carotid artery stenting. We had this series of 5 patients. The onset was within 30 minutes to 14 days post carotid artery stenting. So remembering that paper, just continued with the treatment. Between day 2 to day 6, there were frequent seizures of almost 6 to 8 per day, and there was dense left hemiplegia. Unfortunately, on day 5, he also developed alcoholic withdrawal syndrome, but it was managed. By day 7, the seizures started reducing, and from day 8 onwards, there were no further seizures. Finally, on day 11, I was quite elated when I could see his left hand movements, left leg movements absolutely normal. Even the speech was way better. So I could finally discharge him on day 16 on ecosprin and ticagrelor twice a day, statin, antiepileptics, diabetic and hypertensive medications. Followed up 6 weeks and 6 months later, the patient was ambulatory. There was no left-sided weakness. The speech was normal, probably a smile. 6 months later, the routine investigations during this follow-up, I mean, he was being maintained on dual antiplatelet, but LDL was still anhydrostatin and LDL was still 148. USG was unremarkable. The only thing notable was this continued raised hemoglobin and PCV, but JAK2 mutation for polycythemia vera was negative. 8 months post stenting, during follow-up, the patient was ambulatory, independent, no seizures, no weakness. So kind of the feeling of inner peace. But it did not last long. So he presented a month later with sudden onset painless vision loss in the right eye. There were no limb deficit that time. The vision was just perception of light. Left eye vision was still better. Ophthalmologist found a cherry red spot with an impression of retinal artery occlusion, central retinal artery occlusion of the right eye. Again, this was a side which I had stented. So my first worry was something had gone wrong on that side. MR angio was repeated. Fortunately, there were no infarcts, just the chronic ischemic changes, which were seen earlier MRI also. Looking at the MR angio, so this was the stent artifact, which shows as a gap sort of. This is mild to moderate stenosis of the left side. But the new finding was there was left M1 stenosis, which was totally new. So what is happening? Although with this MRI, the thing was this was still not explaining his vision loss. So try to dig the history. And for his obesity, for weight loss, he had taken tirzepatide. And 4 days after the second dose, he reported vision loss. And he had visited both ophthalmologist and his physician. Although rarely, but GLP-1 analogs, which are being now used for weight loss, semaglutide and tirzepatide both have been reported to have non-arteritic ischemic optic neuropathy. But with our current aim, I think probably this is a story for another time. And this was the thing. After all this time, tirzepatide had something to do in this patient. The new left arm M1 stenosis, which was there on dual antiplatelet, ecosprin and Brilinta. So should I offer angiography again? Should I offer stenting? That just brought me back the memories of previous status epilepticus convulsions and the prolonged hospital stay of the right ICS stenting. So it was it was asymptomatic side. So I decided to manage conservatively. So back to present day, he had this worsening of dysarthria over 1 hour. Speech was getting almost too incomprehensible, and there was just mild right arm weakness. He was ambulatory. He presented to casualty within 1.5 hours of the onset. Now MR angio showed new infarcts. You can see on the left side, patchy, small, not really big. Same the confluent changes. And now the MR angio, again, this is the stent artifact on the right side. But this left side MCA, either it was critically stenosed or there was a large interluminal clot with paucity of the cortical branches. In addition, this time left ICA origin stenosis seemed to be slightly worse, could be severe to critical stenosis on the left side. All the same, it was a small infarct, patchy infarct, MCA distally was filling, it was not totally occluded, and patient was within window period, so immediately thrombolysis was done. There was some improvement in the speech, but knowing that there was a stenosis underlying for last 2-3 months, I suggested stenting or medical management was also discussed, and the relatives opted for medical management at this point of time. Next day, there was worsening of speech. He developed right side weakness, which was much more than presentation, and this all happened in less than 24 hours post thrombolysis. So first thing, needed to rule out bleed. CT scan was done. There was no hemorrhage, and took him up for angiography this time. And as the Ugwe says, one often meets his destiny on the road he takes to avoid it. This was something I was trying to avoid for 2-3 months, and finally it happened again. So during procedure, this is the occlusion of M1 on the left side. I knew there was a stenosis. Straight away took him for the procedure, passed wire, and did balloon angioplasty with 2x10 mm balloon. Post just the angioplasty, the MCA opened up. There was few small clots here, but the MCA opened up pretty well. Knowing the stenosis, uh, did emergency stenting with 2.25 by 15 stent. Post stenting, the artery looked pretty normal. This is how the stent appears. And now I had to tackle this left IC origin stenosis also. So deployed an embolic protection device, as you can see in this, did balloon angioplasty and deployed a stent. This was the only stent available that time on emergency, so deployed it. The final runs 20 minutes later, the MC was feeling pretty well. There were some small minor clots even in the distal branches only, but overall the circulation seemed a lot improved. There was good feeling of M1, and the IC was also pretty well seen. So I was pretty happy with the result. And the next test was also passed. Next day CT, there were just small changes ischemic and the chronic ischemic changes, but there was no bleed, there was no large infarct. So finally, it was possible. He was discharged on almost day 12, day 13. Pretty good comprehensible speech. There was no aphasia despite involving the left hemisphere. Right side was almost 4+5, and he was able to walk with minimal support. Again, continued on dual antiplatelets, statin, and the rest of the therapy. The case had quite a lot of peculiarities. First, this was not a routine stroke case where one would do thrombectomy with stent retrieval or aspiration. There was a known underlying stenotic lesion. That's why I went ahead and did acute stenting. Post-carotid stenting, which is being commonly used now for carotid stenosis, new onset refractory status epilepticus due to cerebral hyperperfusion syndrome is a known but quite rare syndrome. Tirzepatide and semaglutide, both the ones that are being increasingly used, I have been rarely reported to cause ocular ischemic events. Of the risk factors in this patient, polycythemia is known to have hypercoagulable set and increased risk of ischemic stroke. He was obese, probably a component of OSA was also there, and smoking and alcohol. After that first recovery period, he was quite lax and started having both things again. They must have played their part also. And in cases of stenotic lesions, IVT may not always be just the sufficient thing. Please do offer your interventions in such cases also. Finally, to my intervention mentors, thank you.
Yeah, Naren, that was a great case and perfectly managed also.
Thank you, sir.
Just one small doubt. Was anything done for the polycythemia?
No, sir, he was being treated with hydroxyurea. Hematologist
yeah.
opinion was done. That's when they did JAK2 mutation also, but nothing else, sir. I mean, that was attributed to his smoking.
Yeah. So the hematologist did not
That's
advise any phlebotomy or anything like that, apart from
no,
the
sir.
hydroxyurea.
Somehow, no. Somehow,
Because I
no, sir.
noticed that the HB was persistently high in spite of the
Yes,
treatment.
in the same range, 16 to 18, sir.
Yeah. Oh,
I talked with the hematologist. He would advise if it's more than PCV more than 60, and he
okay.
had not touched that line, I guess.
Okay. It's a great case, very well presented, and I think very well managed also. Dr. Rakesh, you want to add something?
I had a great help with sir.
I was partially involved. So nice case. Only thing, all of us know that tandem stenosis and asymptomatic intracranial always a challenge for all of us.
Yeah.
But nicely managed, Naren.
Yeah.
Thank you.
So now here the question is, now this patient, if the patient had undergone MCA stenting when it was detected, probably he would not have had this second stroke. But then we don't
I agree.
as far as ICAD is concerned, we don't do asymptomatic.
Exactly. It was asymptomatic intracranial stenosis. It
But
had
it was
developed
quite
on dual
severe actually.
antiplatelet. Yeah.
Right.
And to be very honest, it just brought me back the first complication. It wasn't a complication per se, but it something happened post stenting, and there was a lot of explaining every day. So I tried avoiding intervention early on.
Yeah, I'm sure. With the patient having spent 16 days in the hospital for carotid stenting, he must be probably very hesitant to undergo another procedure.
Yeah,
And all
absolutely.
that.
Even that post thrombolysis, they waited for some time. Is it really required? Can we wait and all? So yes, I mean it was offered that time also when we did MR angio for the recent stroke.
Right.
And after worsening only they agreed to do the intervention.
Shilpal, you want to add something?
Excellent case.
Thank you, sir.
3 questions I wanted to ask. First is ki you did serial CT or MRI after the hyperperfusion event. So what did you see? Before discharge, there was an MRI or a CT done?
No, sir. That's the CT scan that was done to rule out bleed.
That was on the second, third day.
So immediately same day evening when he worsened.
But later on, have you done any
No,
scan?
sir. No, sir. No, sir.
So it was a gyral edema, what you are seeing on the right side?
Yes.
Post-ictal changes, it was there?
No, sir. The seizure started next day. The
Okay.
CT was done immediately when he developed hemiplegia.
Okay.
So this was done, procedure was done on in the afternoon, and this happened at around 9:30 in the evening. So this was the same day CT. Next day he started getting seizures.
Okay.
So that is why I thought of cerebral hyperperfusion first. So it was probably developing, and he developed seizures next day.
Great. Secondly, polycythemia, as sir mentioned, it was persistently there.
Yes.
I think even if the hematologist says, do not touch, if the hematocrit, if we see HCT, even more than 55, not required to go up to 60, we should do a phlebotomy in such scenarios. Because he is alcoholic, intermittently
his sort of explanation was same, that he is still smoking, he hasn't quit smoking, he might still rise.
Polycythemia
and all
also
sort of
both
things.
is. Right.
Huh.
Third, on dual antiplatelets, aspirin and ticagrelor, he got a stroke, right? You mentioned about the drug which caused anti-obesity drug causing non-arthritic AIF. Okay.
Yeah, that seems sort of an unrelated event, but that is when I found out about that
Right.
asymptomatic stenosis.
Right.
It has been rarely reported, tirzepatide to cause.
And you thrombolized the
cancer.
patient when he was on DAPT with ticagrelor.
So he had taken morning dose. Yes, he came.
So I
This
think
recent stroke was at night.
so that is a statement to be made because many of us, I thrombolize on ticagrelor if the patient
Yes.
is with,
Yes.
but you did with 0.25. People hesitate to thrombolize on DAPT also. And there is a relative contraindication they have mentioned about ticagrelor if patient is
Yes.
there.
Yes.
So,
Yes.
so I think that is also one thing I think you should discuss that.
So during the counseling, the part was should we directly go ahead with the intervention?
Right.
But it was
Right.
quite early in the window period, and they were not immediately ready for intervention. So what can be offered immediately? So at least go ahead with thrombolysis. Might be the cortical branches open up slightly better, and
So
perfusion might improve. That was the
luckily, we did not have a reperfusion injury this side, intracranial.
yes, absolutely, absolutely.
So after thrombolysis also. So
Yes,
ideal would have been to directly go ahead with
go ahead with the intervention.
rescue
Since it was a
study.
documented thing, yeah, rescue
Right.
study.
So excellently managed. Okay.
Thank you, sir.
Your adrenaline would be rushing first scenario and second scenario.
No, it was rushing every time he entered my clinic, sir. He was
Okay.
coming with something or the else all the time.
And whenever
And I,
you were presenting, I knew something is going to happen in next slide, and same thing must be happening
yeah,
with you. Okay,
yeah, absolutely,
great,
sir.
But
great.
one thing
Thank
was
you, sir.
very odd how he developed such severe MC stenosis within
Yeah.
1 year, actually, within few months,
Yeah,
10
yes.
months.
Even, sir, if you look at the ICS stenosis, that has also progressed in the serial scans. The January, I mean, sort of 3 months prior scan and this scan, the
Yeah,
ICS stenosis is also slightly severe at this presentation.
that I can understand because he already had ICS stenosis in the first presentation itself. But the
Yes,
left
yes.
MCA was absolutely normal at the
Yeah,
time of the first
absolutely normal.
presentation.
Absolutely
So,
normal.
Yeah, it's very intriguing. Many times when we are conserving like mild stenosis, suddenly over 8-10 years they are fine, and
yeah,
within a year they develop like 20 to 90 in a year.
yeah,
We
yeah,
don't
it
know why,
happens.
in
Yeah,
spite of controlling all the factors. So
yeah.
many things we don't know. I completely it's a
Yeah,
difficult thing.
and this guy was clearly achromatous, right? He had all the risk factors.
Yes, LDL was persistently high, sir.
Yeah,
I think ezetimibe was also added, but it was still more than 100, 120
Here
at
at
the
least
time.
we had so many risk factors. So
Yes.
yeah.
So there was polycythemia, there was obesity, addictions, diabetes, hypertension.
Yeah. So it was not as if it was non-athromatous disease and then it's
Yeah.
progressed
No, sir. No, sir.
focal cerebral arteriopathy, something like that. But this was clearly athromatous and which came up within 1 year, within few months actually.
Yes, sir.
Great.
I think Narayan will
Thank you.
come back to you again. The way smoking and having alcohol will come back to you again.
Narayan, I hope he doesn't get one more event and you are in a
Yeah, that's what I was about to say, sir. No more events, at least for
He
me
will
to manage.
definitely have it. If he'll continue smoking and having alcohol, nobody
Yeah,
can
yeah,
stop.
you might just land up. Okay.
Thank you, sir.
We'll go to the next case. Vinit, you can start.
Yes, sir. I'm sorry. Just a minute. So is my slide visible?
yes.
Yeah.
So after an interesting case from Narayan, I'll go ahead with mine. This was about a stroke who nobody saw or heard. And so very interesting case. A 43-year-old male with no comorbidities used to live with ailing father who is blind and wheelchair bound. So he cannot move, he cannot see. And he was taking care of his ailing father and was living with him. So now he was brought to our hospital after a day of having a stroke, which was weakness in right upper limb and some aphasia, expressive aphasia, mainly Broca's aphasia. He was able to comprehend. His upper limb power was less, but not zero. It was 3/5. Lower limb was absolutely fine. Now, because he was living with his ailing father, we don't know when did the stroke happen. So, because father could not see and the son could not speak. So it was kind of a situation where there were two people living in the same house, but father cannot move around, the son cannot speak, the father cannot see anything. So it was kind of a very strange and very pitiable situation. Now, only when his father thought that there is something abnormal in the next afternoon, when the son did not speak for some time, after getting up in the morning when his father used to do some stuff, then he realized that there is something wrong. The son is not speaking, and so they said there's something abnormal. So the father called the patient's friend who came from Delhi and brought him to hospital. This was the MRI at admission. So I'll show the photos. So this was the MR. Left MCA infarction, but little or no diffusion flare mismatch. And we did not know when the stroke happened. So he was fine a day before, then he was brought in the afternoon, and we don't know since when did the stroke happen. So we asked the father. He said, I don't know, but he has been behaving strange since a day. So we thought, okay, like it's been 24 hours, and NIHSS, yes, it was high, but not very high. There is no diffusion flare mismatch. Now here, we don't know the time of onset. It is not a typical wake up stroke, but it is time, like the time is unknown. So we thought that there's no diffusion flare mismatch, the patient is not worsening. And we asked the father, has he worsened? And then he was in emergency for some time. We thought, okay, let's wait. We'll not thrombolize right now, or we'll not do interventions right now. And this was the CT angio. So if you can see, there is this MCA stenosis here. So the MCA was severely stenosed, but as he was not worsening, we decided, okay, we'll load with double antiplatelets and we'll observe. We'll decide to keep the mean arterial pressure high, and decided we'll intervene only if he worsens. And it was in the afternoon, so we were in hospital till late in the evening. So we decided, okay, we'll wait and we are around and let's see what happens. And he was in emergency under observation for 4-5 hours. Then he was in ICU for almost 8 to 10 hours. Then after 16 hours of admission, he developed worsening in the form of weakness of right lower limb, despite a mean arterial pressure, which was around 120 millimeter of mercury, quite high. So we decided now we'll have to intervene. And because there was this underlying MC stenosis, we decided, okay, we might need to open. But before we went ahead, we decided to take an MRI to see whether the infarct has progression or there is only edema which has worsened the right lower limb power. Again, aphasia was the same. It was not receptive aphasia. It was not Wernicke's aphasia. It was just Broca's. So we saw in the MR that there is progression of infarct. If you can see here, the MC infarct has progressed, though there is also edema, but there is also progression of infarct. There are new infarcts in the posterior temporal lobe as well as high frontal cortex, especially around motor strip, which were not seen before. So we realized, okay, there is now there is diffusion flare mismatch, there is clinical diffusion mismatch, the infarct is progressing. We decided we'll go in and try to open up the artery. And expected, we went in and did the DSA only to find out that he had a left MCA occlusion. We went in, did a stent plasty, and then because it was tight stenosis. We realized that it's gonna close anyways. So the patient was on aspirin and clopidogrel. So usually when we do intracranial stenting, we load the patient with the ticagrelor Brilinta. And usually we don't do in clopidogrel, but here he was already loaded with aspirin and clopidogrel. So we decided, okay, the loading was done last day before taking him in. As soon as we found the DSA images, we loaded him again. So he was almost on 450 milligram aspirin and 600 milligram clopidogrel. But we decided that this will close, so we decided to go in and do the stenting. And this is how we went in and we opened up the artery. The MCA was opened up. We put the patient on tirofiban infusion, and subsequently uh, the patient improved and he did fine, still taking care of his ailing father. So I think this is one of the transformations that has happened in stroke. We no more care about time, and time is obviously one parameter that we look in. But as of now, we should look at the tissue. Given the fact that he's a young male and he's worsening, uh, with the conservative management, time is no bar for mechanical thrombectomy. Here we did mechanical thrombectomy maybe around 48, 50 hours after the first stroke onset. And we should be aggressive because there has been evolving criteria, and now we'll have to democratize stroke care. And now we are moving into an era where we should have reasons for not treating strokes by IV thrombolysis or mechanical thrombectomy rather than doing so. So, like if you look back at it around 25 years back, there had to be reasons to thrombolize and do mechanical thrombectomy. Now there has to be reasons to not thrombolize or not do mechanical thrombectomy. Thank you. It was a small one.
Dr. Rakesh, any comments? Be there. Rakesh seems to have left. Shripal, any comments? Oh, Rakesh is here.
Yeah. Hi, Vinith.
Hi, sir.
Excellent case. Would you have thought of going immediately once you had seen the MR angio and tried to intervene? Because everyone has this dilemma. Even I have the dilemma to touch or not to touch. We know there is a stenosis. We know the artery may close off within few hours or it may stay, and we may get a time to intervene after few days after stabilization. I think these dilemmas, sir, what do you feel? What should we do in such scenarios?
See, we usually two things. One is we avoid doing ICAD stenting when it's the first episode. And secondly, we avoid doing ICAD stenting in the first 7 days after the index event. So all these cases, GAVE trials have proven that the main problem with the Sampras trial was that they did many of the procedures too early after the event. So it's logical what he did, like he decided to wait when he
Yes.
found the first MCA stenosis. But one thing I would have done differently is that when the patient worsened and you found that the MCA was occluded, you knew that there is an underlying MCA stenosis. So I would not have even used the stent retriever. I would have directly done a
Balloon angioplasty.
balloon angioplasty if the patient had already received the tenecteplase, or I would have done a MCA stenting, right, without even, because we know that there is a plaque, we know that there is an MCA stenosis underlying. So stent retriever is not going to help. In fact, we will just be scraping the plaque more and more by doing even one or repeated passes with the stent retriever. So in a known case of ICAD stenting, although there is no such recommendation, but there are no trials which address this issue. It will be very difficult to conduct such a trial. So when the patient is a known case of ICAD stenosis and the patient presents with an occlusion thereafter, and I think there is a very good case for doing the angioplasty or the stenting directly. Rakesh, what do you think?
I agree. When we know there's a stenosis, we can actually go ahead with the stenting part. Vineet had one question: ki every case you start IV antiplatelet drugs after the stenting? He was already loaded. Most of the time, if patient is properly loaded.
So usually sir, in the cases like where there are planned cases, I usually don't start IV and I usually load with Brilinta. So here the loading was done with clopidogrel. So I was not sure, very sure that the loading was like kind of half loading, not full loading. So we gave 300 in the emergency, and in the next morning we gave him again 300, 150 again. So it was kind of half loading and not full loading, that too with clopidogrel. So I decided not to take the risk and went ahead with tirofiban. If it would have been Brilinta, like in Narayan's case, I would have gone ahead directly and not put him on tirofiban, because that will anyways increase the risk of free perfusion bleed.
Because usually if we load with 4, if 6 hours are over, most of the time it is working. If you're loaded with 8, 2 hours is more than enough. So, fair enough.
One
There
thing,
no.
like you said, like you would have proceeded with the stenting. Like, how do we exactly know, like with this occlusion, where actually the stenosed part in, and what segment is stenosed? Because if you look at the first picture in the DSA, we don't see any anterograde flow here.
Your
No, but you
CT
had the
angio
MR
shows.
angio of previous
Your
days.
CT angio.
Yeah,
You
so
had
he's done
the
CT angio.
Yeah,
MR angio of
proximal
CF.
M1.
Two things, and when your wire is going, no wire will tell you whether it is a stenosed or not. You must have seen yourself when you're passing through the stenosis, your wire will tell you it is stenosed or the clot is there. So most of the time, it's a relative idea.
Sir, any thought of IV cangrelor here in a rescue stenting? Just a thought.
Yes, when patient is on table and antiplatelet naive, then
Yeah.
we use IV cangrelor.
And after 2 hours, load with ticagrelor and slowly
No,
reduce.
what we usually do is we give ecosprin, means disprin at, see, outside IV ecosprin is available. Unfortunately, we don't have.
Right.
So what we do, we load on table ecosprin and ticagrelor. We give cangrelor, and after 2 hours we stop it, because anyway it means ticagrelor is working.
Okay.
Where cangrelor is not available, then we continue IV antiplatelet drug for 4 to 6 hours, depending on which drug we are using.
But you prefer tirofiban or cangrelor? Because tirofiban, we are used to it since very long time right now. At least
Cangrelor
3 4 years.
advantage is like a bolus, no? So you are
Right,
given and you are
right.
done. So it's like giving a bolus dose.
Right.
So
Sir, infusion is there. Cardiologists prefer to be continuing infusion.
we are always scared about
Right.
because all
So only
these
we are
drugs,
not very sure. Okay.
these drugs we are using in acute setting where already infarct is there.
Right.
So our half worry is always bleeding.
Right.
So we are always on the conservative side. And second thing, once you place a stent and there is no intra-stent clot post stenting, then most of the time it is working.
Right.
In Vinith's case, I would have just taken check shoots for 25-30 minutes.
Yes, absolutely.
And if no thrombus in the stent would have been found, I would not have given the
Absolutely.
tirofiban.
Sir, he is already loaded with
He's already loaded with a lot of
yeah.
So
clopidogrel is something, sir, I don't trust.
True.
No. See,
True.
we should not write it off. See, since last 10, 15 years, we are using the drug.
Yeah,
Ticagrelor we are using since last 2, 3 years only. No?
See, if there had been any issue with clopidogrel, he would have developed some clot in the stent. No? And
Absolutely.
usually these clots develop within 5, 10, 15 minutes. Of, right? It's very rare that on table there is no clot and later the patient develops clot. Usually never happens. So is there some way where the participants can send questions? Dr. Shrutal?
So
Yes, sir,
we have-
there is a separate link for the participants to ask the questions, but currently there are no questions from the
There are no
participants.
questions. Okay, fine.
No, sir.
Okay.
Sir, I wanted
Just one question has come up, sir. I think it is for Dr. Vineet. It says, how much dose would you give for cangrelor?
I'm not used cangrelor much, so I still am old school. I still go with tirofiban. I don't use cangrelor.
Rakesh, you can answer that question.
I also won't remember offhand, but whatever they have a loading dose and a continuous dose.
Yeah.
So we give only loading dose.
Sir, ideally 30 mcg per kg is the loading per minute. So they mention in neuro interventions we should use only half of the dose. That is 15 to 20 mcg, 15 only. And just load it, load with ticagrelor, and after 2 hours, if you are giving infusion, at least for 2 hours, and then stop it immediately.
Okay.
And infusion dose loading is 15, that is ideally 30. So half dose is 15, and maintenance is 4 mcg per kg. So that can be up to 2 to 3 mcg. Half dose we should use.
Both. Acha.
Both. I have used for 2 patients. One bled, which I had shown in the complication meeting, and patient had aspirin and rash with aspirin and clopidogrel. So we had to use that, and he bled with that also.
I have used 4 to 5 times, and all times only loading I have given.
Okay, sir. Okay.
So only loading and then nothing else.
Okay.
So touch wood, as of now, I don't know, it's a too small number to conclude something.
Is there any other question?
Sir, I wanted to ask Narayan one question. Narayan,
Yes, sir. Yes, sir.
so what was the cause for cerebral hyperperfusion here in your patient? The BP was normal, MAP was maintained. So what,
Yes, sir.
like
The
pathophysiology?
risk factor that we usually see in cerebral hyperperfusion is one thing is there is a contralateral severe stenosis also.
Here it was
So
not moderate, it was.
it
But
was moderate.
right.
It was moderate. It was just this thing severe. Not
But
really sure, sir, what would
But
have
you
triggered it.
remember you did MCA stenting. From the ACOM also, right MCA was filling, right AC and MC.
Yes, yes.
So I think there was a contralateral flow also that time also.
So it seemed like the one that you are speaking of, probably it was a check shoot by a distal access catheter from supraclinoid IC or somewhere near about that. But while I
Okay.
did DSA, there was not much of cross flow from left side to right side.
Okay.
But yes, there was no obvious reason per se. The BP was not raised. It was not a critical stenosis on the other side. This was a fairly regular case, the ipsilateral severe or to critical stenosis, and right side maybe mild to moderate.
Now, what should be the take home for every patient undergoing carotid to avoid cerebral hyperperfusion? From your case, or what you must have reviewed?
Generally, is to maintain the blood pressure.
Perfect. But
The
that
blood
was
pressure should
always
not be
low.
more than that.
Yeah.
That was always low. But
Right.
that is the one thing that I usually stress upon. So apart from giving dual antiplatelet, it's important to look at the BP all the time.
Okay.
And it's always a stage thing that we do for bilateral stenosis. And studies have reported to do perfusion scanning before stenting, but it's something we hardly do.
Very
While
difficult.
writing that paper, while I read the literature, they reported doing perfusion scanning, but it's not something that we do commonly.
Right.
So I guess perioperatively, just before the operation, also sometimes the BP is quite higher.
Okay.
So if we get a couple of days of time, we should check that blood pressure and blood sugar are well within the range to prevent perioperative complications. It's a rare thing. Of all these carotid stenting that both Karapur Dastar and Rakesh Singh sir had, we had just 5 cases during my residency.
Yeah, it's actually very rare, but sometimes it is just bad luck.
Right.
Only risk factor is many times just severe stenosis. That's all.
Yes.
Because you manage the BP very well, and still the patient gets hyperperfusion or even a large bleed. So it is just bad luck.
Notes we found that if the patient has a scar
Okay.
and the severe stenosis, then
Yes.
the chances of NARS are pretty high.
Right.
Okay.
Because all status patient we had a scar there.
Okay.
Yeah.
So that may be one of the factors.
So we have two more questions. One is from same Dr. Abhishek Bhoyat. His question is, cangrelor through catheter near thrombus was given, or was it an IV loading? And also, any such difference between the cost of tirofiban and cangrelor, and in terms of availability as well?
See, cangrelor is IV drug. So we
Right.
give it IV.
Right.
Intra-arterial, we don't have much, what you call,
Secondly, the cost of drug Cangrelor is available in most of the cardiac cath labs, and it is costing from 12 to 16,000. Whereas tirofiban we get, I think, Agramed or something 5,000 or 6,000 maximum.
The same. Including infusion, it becomes 10. It is similar.
Okay.
But Cangrelor is costlier, definitely.
Right.
Sir, and there is one more question from Dr. Pavan Pai, sir. He has asked, is there any role of the sale technique in the second case?
Vinith?
So, safe technique obviously can be used for mechanical thrombectomy in any case as such. Here we were like, the only reason I did mechanical thrombectomy was to localize the lesion, how big it was. So, deep down, I knew that there's underlying stenosis, and I had to, like, I will have to stent because there was progressive deterioration. The only reason I did mechanical thrombectomy was to localize the lesion, because even while it was filling partially through ACA, I was not able to exactly choose the site where I need to put in the stent and do a balloon plasty. And I did not want to just go in and try my luck. So I did mechanical, but yes, safe technique can be used, but then the result would have been the same.
So thank you. I think that's all the questions we have.
So thank you, everyone. Thank you, both the case presenters. Both were very good, excellent cases. Thank you, Dr. Shripal. Thank you, Dr. Rakesh.
Thank you, sir.
Thank you.
Should we call it a day?
Yes.
Yes.
Kalpita?
Yes, sir.
Okay.
Firstly, I'd like to thank each and everyone, Dr. Shripal, Dr. Alurkar, Dr. Rakesh, Dr. Vineet, and Dr. Narayan. I think it was a fantastic presentation from both our speakers, followed by an excellent panel discussion. And for today's event, we have around 100 doctors who have joined us for this session. And I'm
Right.
sure each and every one of them must have benefited from the cases as well. And going forward, we look forward to more such interesting cases in our upcoming SIS series. So thank you everyone once again from Team
Thank you.
Gennova.
Good night.
Good night. Thanks a lot. Thank you.
Bye.